Hi, right, so we have the next 10 questions coming up, 16 to 25. When we get to 25, it means we're halfway through the medical Viva revision. Right, let's get into it. 16, question 16 is a 43-year-old male, has type 2 diabetes since the age of 28. Not worried about it, so that immediately tells you health literacy probably low, because you should know you should be worried about type 2 diabetes. He reports burning feet, right? So he's got peripheral neuropathy, keeps him awake, so it's significant enough that it's causing dysfunction in his sleep cycle. His BMI is 38, so he's obese and qualifies very closely for morbid obesity. He does have diabetes, so immediately makes you think, should he get bariatric surgery? Blood pressure is uncontrolled, so he's got hypertension. If that's not been diagnosed, it needs to be diagnosed. He's got proteinuria. So main things I'm picking up here are diabetes, microvascular complications of diabetes, that needs management. Diabetic control needs to be checked because these things have gone off because that's not been checked. Microvascular disease is related to glycemic control. You should know HbA1c is the standard which you measure that by. Above 7 you get more complications on a microvascular level. He should also be screened for vascular disease. Diabetes, his blood pressure should be well controlled. His obesity needs attendance. So once again, a lifestyle issue here. If lifestyle fails, bariatric surgery is definitely a consideration. So those are my main thoughts here. In 17, you've got a 28-year-old male, multiple sexual partners, STI screen is positive, HIV and gonorrhea. What is the management of the situation? That clearly is treatment of his gonorrhea, checking on his HIV, where are we in terms of viral load, CD4 count, treatment. Then, important, don't miss the opportunity to mention contact tracing, because the patient most certainly is at risk of spreading his HIV, and contacts need to be informed. If that is possible, that will depend upon whether the patient is happy to cooperate. So you have to discuss the ethical, moral issues around that. So an ID question, really. 18-year-old, question 18, a 56-year-old, routine checkup. And then, by the by, long-standing productive morning cough. And in the last year has developed shortness of breath. So this means this patient is at risk of chronic bronchitis because he does smoke, 35-year pack history. His wife's keen for him to quit smoking. Is that a good idea? Definitely. Prevent the further deterioration of lung function. You want to first of all check whether this patient has lung carcinoma. If the patient does not, work him up for COPD. What would you do to do that? Spirometry. Discuss bronchodilators. Discuss the role of where does inhaled corticosteroids come into all of that, which should be right at the end, right? But you know that. Referral to pulmonary rehab. Discussion of prognosis of COPD in the long run. Does it differ? Check whether he is hypoxic, need for oxygen therapy, in other words, vaccinations, flu, COVID, pneumococcal, and now RSV. Question 18. 88-year-old male is admitted with recurrent falls. He has lived alone. Wife has passed away 6 years ago. Background history of type 2 diabetes, high blood pressure, chronic kidney disease, and ischemic heart disease. So multimorbid, vascular history, worsening cognitive impairment. Allied health review determines that he's not safe to return home alone. So in other words, that is not an option. he refuses nursing home placement. This really is a geriatric patient that will need MDT input. You will do a workup for dementia. You'll see whether the patient has a low MOCA. You'll also check whether the patient has depression, which can mimic dementia and delirium, which gets me to the last D, right? The 3Ds, delirium, dementia, and depression in geriatrics. They can all three look the same. So make sure that the patient does not have a delirium. Do a basic workup. In other words, the bloods that you would have seen on a medical ward round. And then lastly, you are considering doing a capacity assessment on this patient. But given the complexities, you would be consulting a geriatrician, because this patient probably will need someone to make decisions on his behalf, as refusing nursing home placement is not a realistic option. 63-year-old female with stage 4 breast cancer has had all the treatments in Australia and now wishes to pursue treatment in the USA. This is more about not as much the treatment as what it is about deciding what is important in life. If treatment fails, it is stage 4, time is of the essence. The reflection should be, is it worthwhile to spend your time in the USA abroad if time is running out? Are there other priorities in life? Should that not be weighed up? It will be different for every person. 80-year-old male is in the hospital recovering from a skin graft for scalp SCC. So he's had an intervention, is recovering, background history of hypertension, end-stage coronary artery disease, heart failure with preserved ejection fraction, type 2 diabetes and CKD. So usually all those conditions have hypertension as a manifestation, CKD in itself, type 2 diabetes. Coronary artery disease later on could have hypotension as a feature, but only if it's getting to advanced heart failure. BP is usually around 100 millimeters systolic, and the ward staff are requesting a change in the emergency calling criteria. How would you manage this? This patient cannot have a altered calling criteria until fully assessed and there is an agreement with the team that this is appropriate to do so. If this patient has been hypertensive up until now, this may in actual fact be a too low blood pressure and may need further adjustments, for example, adjusting medications and maintaining an altered calling criteria that is for a higher blood pressure. Once all that has been done, yes, a blood pressure altered calling criteria may well be appropriate, but only after assessment. A 58-year-old man presents with a 2-month history of right upper quadrant discomfort and weight loss. LFTs are null, but there's a solitary mass in the liver. How would you assess him? So the question here is, does this patient have hepatocellular carcinoma, or its differential diagnosis, a metastases to the liver? Your approach here will be to have a history to check for carcinoma carcinoma symptoms, including, for example, weight loss, loss of appetite, any other areas that could be the primary source. It is a male, so think about that. What are the common cancers in this patient? Or what are the common cancers this patient could have? Then apart from that, will be to determine what kind of imaging you're going to suggest. You already have bloods and upper quadrant ultrasound imaging. What I would suggest here then is a quad phase CT scan or MRI with a special contrast study to determine whether the lesion is in keeping with HCC or a metastases. 82-year-old woman presents with shortness of breath and is found to have a moderate-sized left-sided pleural effusion. How do you assess and manage her? Right, so this is the classical pleural effusion. I've discussed it in my first video as an introduction to this year's Viva. Basically, it's the crux is transitive versus exudate, the causes of those, know those, but be able to introduce the topic that you'll be doing a history and physical examination looking for those common causes, like, for example, heart failure, liver disease, nephrotic syndrome, pneumonia, malignancies. A 40-year-old man develops acute back pain after heavy lifting 3 weeks ago. So acute back pain, now has sciatica, possibly has a nerve impingement, and he asks whether he should go for spinal manipulation and what should you advise him. Always contentious when alternative branches of medicine are introduced. Usually it's safe to say, look, evidence is the following, would recommend, not recommend. If the risk is low, give it a go if you want to see if it works for you. Here, you probably do need to point out that scientifically the picture is that suggestive of a radiculopathy, and spinal manipulation could in actual fact make that worse. So you would be very worried if he were to pursue the pathway of manipulation. So although you are usually open to other modalities of treatment, in this instance, your background dictates that he must in actual fact not attend this as an option. Right, so last one, and then we're halfway. 18-year-old man leaving for a year's holiday trekking through Southeast Asia. Seems like a very realistic consultation. What advice would you give him with relation to staying healthy? So right, so this is one, an ID question. Two, it is travel medicine. All of those combined. So vaccines, know what vaccines you would suggest, and then what other disease that has vaccination maybe is an option nowadays. Not quite there yet in the mainstream, but is malaria, and other conditions that you may find there is things like rabies. Right, so that definitely is a travel medicine and ID question. Right, so that's it for this session. I'll see you soon for the second half of the Viva questions.